Welcome to my presentation on Stevens-Johnson syndrome. My name is Nathalia Rivera. I'm a registered nurse studying at the College of Nursing at St. Petersburg College. We will briefly discuss Stevens-Johnson syndrome. Stevens-Johnson syndrome, SJS, is a rare, severe skin and mucous membrane disorder. It is often triggered by an adverse immune reaction to certain medications, such as antibiotics, anticonvulsants, and non-steroidal anti-inflammatory drugs, NSAIDs. In some cases, SJS can be caused by infections, including viral infections like herpes or bacterial infections like pneumonia. It typically begins with flu-like symptoms followed by a rash that spreads, causing the top layer of the skin to die and shed. SJS is considered a medical emergency and requires immediate hospitalization. Ban 2024. The objective of this presentation is to explore Stevens-Johnson syndrome, including its impact on the population, etiology, risk factors, pathophysiology, clinical manifestations, complications, treatment, and nursing evidence-based practice. The image to the right is a patient with severe form of Stevens-Johnson's. SJS can lead to significant morbidity and mortality rates within the United States. In addition, the severity of the disease also accounts for an increase in healthcare costs. The impact of SJS will be looked at by incidence, prevalence, mortality, and costs. National incidence is estimated to be between 1 to 6 cases per million people per year in the U.S. as of 2020. SJS primarily affects those individuals exposed to high-risk medications, certain antibiotics, anticonvulsants, and non-steroidal anti-inflammatory drugs, NSAIDs. Su et al. 2016. Prevalence. SJS prevalence is 5.76 per million population in the U.S., typically those exposed to high-risk medications, based off of reports between 2010 to 2020. SJS is more prevalent in populations using specific medications, including individuals with HIV, AIDS, who have a 1,000-fold increase of developing SJS. Mortality rate. Mortality for SJS is 5 to 10%, with higher rates in older adults and in those with comorbidities who have been diagnosed with SJS. Mortality rate increases significantly in patients who develop toxic epidermal necrolysis, 10, a more severe form of SJS, with mortality rates ranging from 30 to 50%. Mortality is also higher in patients with extensive skin involvement or delayed treatment. Su et al. 2016. Healthcare costs. The average cost per hospitalization for SJS is approximately $77,000 per patient. The cost will be more in those patients who develop TEN and require invasive intensive care. The cost also reflects specialized wound management required for SJS patients, often including prolonged hospital stays, the use of burn units, and specialized medications. Costs can escalate in patients with extensive skin involvement, infections, or complications. The economic burden is estimated to be around $42 million annually. Su et al. 2016. Etiology of Stevens-Johnson syndrome, SJS. As previously stated, SJS is a severe rare disorder of the skin and mucous membranes. It results from an immune-mediated hypersensitivity reaction triggered by medications or infections. This leads to flu-like symptoms followed by a rash that causes the top layer of the skin to detach, slough, and die, seen 2017. The most common cause of SJS is adverse drug reactions. Medications that frequently trigger SJS include anti-epileptic drugs, carbamazepine, lomectin, antibiotics, particularly sulfonamides and penicillin, NSAIDs, non-steroidal anti-inflammatory drugs, especially oxycams. Allopurinol is often associated with SJS in patients with specific genetic predispositions. Infections are the second most common in triggering SJS but occur more frequently in pediatric populations. Mycoplasma pneumonia, herpes simplex virus, HIV. In some cases, the trigger remains unidentified, resulting in idiopathic SJS. These cases require further investigation into potential underlying mechanisms. For SJS are mostly non-modifiable with a few modifiable factors. Non-modifiable risk factors include genetic predisposition, age, gender, and previous history of SJS. Genetic predisposition is related to human leukocyte antigen alleles found within certain populations. HLA are proteins found on the outside of the body cells and are specific to everyone. As a result, HLA is an essential modulator for immune responses and drug hypersensitivity for that person. For instance, HLA-B 1502 is found in Southeast Asian populations and are associated with carbamazepine reactions, while HLA-B5801 is linked to allopurinol in Chinese populations. Cloy-Pan et al. 2021. Age. Drug-induced SJS is more common in adults, while infection-induced SJS is more frequent in children. However, SJS can affect anyone at any age. Gender. Some studies suggest that females may be slightly more susceptible to SJS than males, particularly for drug-induced cases. Previous history of SJS. Those with SJS previously are at higher risk for recurrence. Modifiable risk factors. Modifiable risk factors include monitoring drug use, genetic screening, managing immunosuppressive states, and maintaining infection control. Monitoring drug use and screening. Patients and physicians must avoid or carefully monitor high-risk medications such as antiepileptics, antibiotics, NSAIDs, and allopurinol. Doing so can reduce the risk of SJS incidence. In addition, genetic testing for specific HLAs such as HLA-B1502 can help prevent drug-induced SJS within certain populations. Immunosuppressive states. Patients with compromised immune systems are at higher risk for developing SJS. This includes those with HSV or HIV. Proper management of these infections, along with antiviral medication compliance, can reduce the risk of incidence. Infection control. Preventing infections such as mycoplasma pneumonia through vaccination or general infection control protocols can help lower the patient's risk of SJS. This is especially important for pediatric populations and those who are immunocompromised. It is important to differentiate between modifiable versus non-modifiable risk factors to prevent and minimize the risk for SJS. The pathophysiology of Stevens-Johnson syndrome is believed to be primarily a T-cell mediated cytotoxic reaction. Drugs or infection can act as antigens that bind to host tissues to create an immune response. As a result, cytotoxic T cells and other immune cells are activated, which release pro-inflammatory cytokines. These cytokines include tumor necrosis factor, Fast ligand, and granulosin. These cytokines play a crucial role in the body's immune response. For example, TNF is a key mediator of inflammation, while Fast ligand and granulosin are proteins responsible for triggering apoptosis. Raban et al. 2021. Once the immune system is activated, keratinocytes are targeted through the Fast-Fal pathway and other cell death pathways. This leads to widespread cell death and detachment of the skin's epidermal layer, which is the hallmark of SJS. Granulosin, a protein released by cytotoxic T cells and natural killer cells, is a key mediator of this keratinocyte apoptosis. Franz et al. 2021. As keratinocyte apoptosis occurs, the epidermis detaches, causing large areas of necrosis, which results in a loss of the skin barrier. This leads to a risk of infection, fluid loss, and complications similar to those seen in burn patients. SJS affects the skin and mucosal surfaces, including the eyes, mouth, and genitals. The mucosal involvement often leads to serious complications like conjunctivitis, keratitis, and severe cases blindness. As you can see in Figure 2, this patient appears to have a second to third degree burn. However, this is a presentation of SJS, and oftentimes the patients are treated in the same manner as burn patients due to the loss of skin. Hafiz and UAE 2021. SJS has a range of clinical manifestations that progress through various stages and can affect multiple organ systems. Subjective findings include fever, malaise, headache, sore throat, joint pain, and eye discomfort. Middle-late stage includes skin pain or tenderness with visible lesions, difficulty swallowing due to mucosal ulceration in the oropharynx. Objective physical findings include the skin with macules with a rash that starts first on the face and trunk. Lesions then evolve into target-shaped lesions before progressing to bullae. Widespread epidermal necrosis and shedding of the outer layer of the skin with a positive Nikolsky sign. Nikolsky sign is when the skin peels off easily with slight pressure is applied. Mucus inflammation or redness in early stages, followed by severe ulceration of the mouth, lips, eyes, genitals, or respiratory tract in late stages. Respiratory. Cough, dyspnea, or failure due to sloughing of the respiratory lining. GI, ulceration of the mouth or esophageal structures leading to severe GI bleeding. Diagnostic tests include elevated white blood cell count and a CBC with decreased lymphocytes. Skin biopsies, which are the gold standards of diagnosing SJS, as keratinocyte apoptosis will be prominent with full thickness necrosis. Serologic tests will identify anti-inflammatory markers such as increased C-reactive protein and erythrocyte sedimentation rate. X-ray will be looking for signs of pneumonia or ARDS. Liver function tests will determine the severity of organ failure. Nagan, 2003. SJS that covers more than 30% of the body with organ failure presents as an extremely high mortality risk. Complications include skin infection, sepsis, vision loss, organ failure, and death. Hospital for SJS requires treatment that is immediate and provides both acute and direct patient relief in order to halt disease progression. Two most commonly prescribed treatments include medications, corticosteroids and cyclosporine. Corticosteroids are used in the early stages of SJS to reduce inflammation, suppress immune activation, and prevent further damage to the skin and membranes. Corticosteroids can provide rapid relief when administered early. Methylprednisone, for example, reduces the production of cytokines causing cell death. It decreases the activation of the cytotoxic T cells and prevents the migration of immune cells to the site of skin damage, HARD 2020. In doing so, it suppresses the inflammatory process, thereby reducing swelling, redness, and pain associated, while preventing further skin death and detachment. It aids in the faster recovery of the skin and membranes. Methylprednisone is given intravenously for rapid onset on a schedule with doses tapered over time to reduce side effects. The dosage for methylprednisone is 50 mg IV every 12 hours for 12 days. Ayung and Lee, 2018. Cyclosporine therapy is a suppressive agent that is used to halt the progression of SJS by inhibiting T cell activation. It has been found to decrease mortality rates in SJS patients and prevent skin detachment by targeting the immune response at the lowest cellular level. Cyclosporine binds to a protein that is required for T cell activation and blocks the transcription of the cytokines. In blocking the transcription, cyclosporine reduces the destruction of the keratinocytes and destabilizes the skin barrier. This promotes faster healing. Sal et al. 2020. Cyclosporine is administered orally or intravenously in controlled hospital settings. Dosages are adjusted based on the severity of SJS and the patient's response. However, initially will be 3 mg per kilogram IV daily. Ayung and Lee, 2018. Critical elements of SJS include early identification, wound care similar to burn management, fluid and electrolyte balance, pain management, infection prevention, psychosocial support, and nutritional support. Early identification. Nurses should be trained to recognize early signs of SJS, including fever, mucosal involvement, and skin changes, such as targeted lesions and blisters, to initiate rapid treatment. Prompt recognition and early intervention are crucial for improving outcomes. Nurses can include doing thorough and frequent skin assessments to identify lesions that could indicate SJS in those taking high-risk medications. Wound care and infection prevention. The wound care of lesions in SJS is similar to that of burn patients due to their significant injury to the skin. Nurses should ensure proper wound care using sterile techniques to prevent infection and applying appropriate dressings to promote healing. This includes infection containment from outside sources as these patients have lost their skin barrier. Nurses should know that anyone entering the patient's room should be fully gowned with gloves, a mask, and a bonnet. Fluid and electrolyte management. SJS can cause significant fluid loss due to widespread skin detachment, similar to burn patients. Maintaining fluid and electrolyte balance is a critical nursing responsibility. Nurses should monitor intake and output hourly and look for signs of decreased output, volume deficits, and collaborate with physicians to consider nephrology. Pain management. Patients with SJS often experience extreme pain due to mucocutaneous involvement. Nurses must collaborate with physicians to ensure effective pain control. Both pharmacological and non-pharmacological considerations should be taken into account. Psychosocial support. The psychological impact of SJS can be significant, with patients facing physical disfigurement, long hospital stays, and isolation. Providing emotional support is a key part of nursing care. Nutritional support. Mucosal ulcerations in the mouth and gastrointestinal tract can make eating difficult for SJS patients, requiring alternative nutritional support. Hansen and Betancourt, 2020. The remaining slides provide the sources of information used for this video.